Hi, everybody. Welcome back to Pediatric Echo. Today we're going to be learning from Doctors King and Higa about return to sports after concussion and some work that they've been doing here locally. And unfortunately, we don't have CME. We had some snafus with the paperwork, so we apologize to those of you that are counting on CME. We won't be able to offer CME or MOC credit for this session, but I think we still have a lot to learn, and we're looking forward to learning from some experts. As usual, I will be kind of keeping an eye on the chat and making sure that if there's any kind of clarifying questions right in the moment, like what does this mean, or that kind of thing, then I might interrupt the speakers to get that clarity. Otherwise, we'll have some time for discussion and or questions at the end. And without further ado, I'm going to pass it off to our wonderful speakers. So thank you and look forward to learning with you all.
Thanks, Maya, for always organizing all these awesome talks with Echo. I'm Jen King. For those of you that don't know me, I'm a pediatric and adolescent sports medicine physician and have been the medical consultant for the Hawaii Concussion Assessment and Management Program for almost 20 years. It's been a little crazy. So this portion, we're actually going to talk about return to learn. And Dr. Higa is actually going to be the star of this show, but I just wanted to give a little bit of background. As far as we know that over the past 2 decades, concussion management has really changed a lot. The pendulum's kind of swung all over the place. So now we're in a place where we do want to recognize a concussion and get them out of harm's way at the moment. But then we do want to get them back to school, back to activity as soon as we can, with some adjustments in the beginning as needed. And this is where this return to learn portion is really critical. As we know, a lot of middle schoolers and teenagers don't want to be stuck at home with their parents for any more time than they really need to. So we do want to get them back to school for that social aspect, but also try to make sure that they're not changing their circadian rhythm too much by being at home. So that part has been really integral. And also just a little plug for if they're not turning the corner as far as symptoms in 7 to 10 days, they're probably going to need some rehab. So we do want to get that activated fairly quickly and not let them sit around for too long without some active management. With that, I'm going to allow Dr. Higa to introduce herself. It is so awesome to be able to work with her, and she has been such an amazing addition to HCAM. So I'm so glad that she's able to share all this knowledge with you.
Thank you, Dr. King. Hi, everyone. I am Jamie. Actually, I am going to share my screen first because I can't multitask. Okay, here we go. All right. I'm Jamie. I am a psychologist and I work with the Hawaii Concussion Awareness and Management Program. We are located out of the University of Hawaii inside the College of Education. So as Dr. King was mentioning, she's been a consultant with HCAP for almost 20 years now. And it's a pleasure to overlap with her and get to do a bunch of fun concussion talks and just general education and awareness to the community. As she mentioned, we're going to be talking about back to school today, and we want to focus on return to learn strategies after a concussion. So this is Dr. King's disclosure slide, nothing to disclose, as well as me, nothing to disclose. So today we're going to be talking about applying current evidence-based return to learn practices to support your patients throughout the concussion recovery. And what we really want to focus on is the initial recovery phase, so that first 1 to 4 weeks. That's going to be the primary focus of today, and we're not going to get into too much of that protracted cases. And we want to also talk about identifying appropriate academic adjustments for that early phase of return to learn. So again, that first 1, 2, 3, 4 weeks. And then we'll discuss identifying how to identify premorbid neurodevelopmental and mood disorders and how they influence concussion symptoms and the recovery trajectory. So for anyone that's located in Hawaii, I'm not sure if you are aware, but we do have a concussion law. In fact, all 50 states have there is a concussion law. In some states, it's named after the athlete that passed away from second impact syndrome. So in Colorado, for example, it's named the Jake Snakenberg law, who was a football player and passed away from second impact syndrome. For us in Hawaii, it's called Act 262. There are primary components in this law that includes annual education and awareness, mandatory removal from play, medical clearance. It targets 11 to 18-year-old athletes. There's graduated return to play protocol that's discussed in the law. But what I want to highlight today and just spend a minute to focus on is that we actually do have some return to learn language that's in our Hawaii concussion law. The intent of the law is not to legislate how schools are managing concussions. And I think that's an important distinction because I don't think that we should legislate return to learn practices. In some states, they do that. In Hawaii, that is not the intent of our law, but we do have statements like it may require the student to follow a plan. And so with Act 262, it's saying that we want to include periods of cognitive rest and physical rest while symptoms of a concussion persist. And then we also want to reintroduce cognitive demands on a progressive basis so that we're preventing the significant reemergence or worsening of symptoms. So this is the language in the law as it pertains to getting a student back to school and managing those symptoms in the school setting. So when we're thinking about return to learn, right, what is the overall concern? But when we look at the data, right, we're seeing that about 24 to 30% of concussed students are reporting a decline in school performance or that there's this effect on their school attendance. And then also about 45% are experiencing a worsening of symptoms when they return to school. Right, so that's a large number of students that are being impacted in the school setting when they're going back to school after sustaining a concussion. But what about the students in Hawaii, right? We do know that our population it's culturally diverse, it's linguistically diverse, and we're often not represented in these studies that are performed across the states. And so what we did, HCamp in partnership with Dr. King and you here on P20, is we decided to do a study and look at the impacts of our Hawaii students. And so for those of you that don't know, P20 is a state agency and it tracks DOE data. So they have access to things like GPA records, behavioral infractions, absenteeism, college acceptance rates, SAT scores, ACT scores, so on and so forth.
Dr. Higa,
yes.
I'm so sorry to interrupt. There was a question in the chat asking about the 25 to 30% and the 44%.
Mm-hmm.
Are the 25 to 30% part of the 44%? Sorry to interrupt.
No. Those were actually two separate studies.
Okay, thank you.
Mm-hmm. And so with our P20 data and then Hawaii or HCamp's concussion incidence data, we combined our databases and we handed it over to the very smart folks in the econ department, UHERO. And what they did was they looked at this causal relationship. So they weren't necessarily interested in looking at associations between concussions and various outcomes. They wanted to run a causal analysis to say that, yes, concussions are causing or not causing specified outcomes. And so with that, when we looked at all of that data, what we found were that student athletes in Hawaii that had experienced 2 or more concussions in their high school career had experienced about a 1-point decrease in their annual GPA. So what that means is if prior to their concussions, they were at a 4.0, after 2 concussions, they were at a 3.0, for example. And this was primarily driven by declines in math by about 1.04 points and science of 0.33. What they also found in the data was a 13% increase in behavioral infractions for this 2+ concussion group. And so what we know, right, is that concussions are affecting our Hawaii students academically, they're being affected behaviorally and social emotionally, likely social emotionally as well. Another data set that we looked at, this is separate from the one that I just discussed, is we looked at sex differences in days to advance through the 6 graduated return to play steps. And again, this is with specific Hawaii data with our student athletes in Hawaii. And we were looking at the recovery rates of our male and female student athletes. So what we were seeing is that females on average are taking about a day longer to recover, about a day longer to move through step 2 to 3. And then in the overall total, you see on the far right, that's going to be how long it took them to get through all 6 graduated return to play steps. They're taking about 2 days longer to finish the graduated return to play protocol and get cleared. However, right, if we really look at these numbers, we are seeing that both male and female students are taking longest to move through this step 2 to 3, right? So what is this step? Step 2 to 3 is the full return to school step. So what we know is that out of all the 6 graduated return to play steps, the biggest holdup is happening when we're trying to get the student back to school full time, right? So our students are struggling academically, and we're really struggling to get them through this step in the RTP protocol. So when we consider all of this data, right, our local Hawaii data, right, we discussed those academic concerns, we discussed those behavioral concerns, and the time to recovery concerns as well. And right, what can we do about it? I think it's important, right, that we're thinking of how we can support our patients, how we can support the students in order to mitigate some of those negative outcomes that we're seeing. And so one of the ways that we can address this is by really focusing on some strong return to learn practices. And this is especially important during that acute phase. So, right, within that first week, we want to get them back, as Dr. King was mentioning, we want to get them back integrated into their life. So this document here that you see on your screen is a return to learn consensus statement. And on the right side of your screen in table 4, those are all the organizations who endorsed these 13 statements. And the 3 bullet pointed organizations that you see up top, they participated in the process, they reached consensus, but they had stated that the endorsement process through their organization, it was too cumbersome and it would take too long. But I just wanted to note that the American Academy of Pediatrics did participate in the consensus statement. So we won't go through all 13 statements, but I do want to highlight some overarching themes that we see. So what we see is recovery is individualized. Every concussion looks different, symptom presentation can look different. Interdisciplinary collaboration is essential, and it's important that there's a shared responsibility among the healthcare providers, educators / school system, and then the families. Early return to school is beneficial when appropriate supports are in place. That would be things like academic adjustments, which we'll talk about in a little bit. School is therapeutic. So even though the patient may still be experiencing symptoms, it's good to get them back into school because it provides academic, social, and emotional benefits to help promote the recovery process. And we should leverage existing educational frameworks. And lastly, access to support. So access to these academic supports should be timely and equitable. Oops. So the first theme that I want to touch on is this interdisciplinary approach. And I know this is not groundbreaking news to any of you. I'm sure you've heard it millions of times, but oftentimes in our concussion literature, this is discussed quite heavily of taking this interdisciplinary approach, and we call it a concussion management team. And the concussion management team is made up of a family team, a medical team, and school team. And it's all wrapping around the patient. And when all 3 of these teams are communicating and collaborating, this helps to determine how we're managing symptoms, right? If various referrals need to be put into place, if we need to add more supports, if we can take away supports, what the return to learn process is looking like. It can help us determine social emotional health. So, right, do we need to provide additional mental health supports? And then, of course, return to play guidelines and the clearance process. The next theme is the existing educational frameworks, how we're leveraging that. So as you all are aware of the public health model, right, there's the primary, secondary, and tertiary. But what you might not know is that in every public school across the nation, mandated by the Department of Education, there is this existing framework, and it's modeled after the public health model, except the Department of Education rebranded it and they called it Response to Intervention, or RTI. It's also known as Multi-Tiered System of Supports, or MTSS, but it is exactly the public health model, except it's called Tier 1, Tier 2, and Tier 3 instead of primary, secondary, and tertiary. And so what does this model look like when we're talking about concussion management? So concussion within this RTI model, and I think this is helpful to know, right, because this is how the school system is going to operate. And so for you to have an understanding of the general understanding of what this could look like, so you know what supports you're recommending. At the Tier 1 level, right, it's going to be that all students with a concussion are going to receive these short-term academic adjustments, and 80% of them are going to get better within a month. The 20% that don't get better, that are experiencing lingering symptoms, protracted recoveries, those students may require formalized classroom accommodations, also known as a 504 plan. I'm sure that some of you are probably familiar or have had patients that had asked for specific accommodations to put into their 504 plan, something like preferential seating or a quiet test-taking environment. And then lastly, it would move up to the Tier 3 level, or special education. At this level, at the Tier 3 level, we rarely have concussion cases that result in a patient requiring special education. In the cases that I have seen or worked with, right, there was some underlying like significant concern that was already pre-existing, and the concussion just added on top of it. So that those students were already at Tier 2, they were already on 504 plans, and the concussion just kind of put them over the edge, and they then required an IEP. So we rarely see concussion by itself causing a student or a patient to require an IEP. So appropriate supports. I want to talk about academic adjustments, right? And what these academic adjustments are. So ideally, right, this is all happening at the universal, at the Tier 1 level. And so I want to spend some time talking about these academic adjustments in the coming slides, and some suggestions that you can make to families or schools in providing these academic adjustments. So we want to front load these supports during the first 4 weeks of the recovery process. And especially in that first week, really front loading them. And as this patient is getting better, the supports can start fading, right? We can start pulling back some of the supports as the concussion symptoms subside. We want these students to get back to school as soon as possible. And when we're providing these supports, that's what we're doing. We're reintegrating them back into school within that first week of the concussion. In fact, we really don't want to wait for symptoms to completely resolve before we send a student back to school. By doing so, it's encouraging, or it is encouraging a prolonged school absence. And what we see that lead to is a delayed recovery. So they're taking a lot longer to get better. And a lot of times this is driven by an increased stress from missing school. They're socially isolated, and there's this increase in emotional symptoms as well. That's anxiety and depression. So getting them back into school quickly, even though they're still symptomatic, will help them recover quicker. So when we think about academic supports, right, whose responsibility is it to direct them? We talked about this interdisciplinary approach, and we have these 3 teams: a school team, family team, and medical team. So who is directing these supports? The Return to Learn consensus statement states that academic adjustments are best overseen by school professionals. So ultimately, it's the school team that should be directing. However, I know that in practice, that doesn't happen. I also know that every school, every teacher is different. And some schools may not want you to participate or be suggestive of what type of supports may be beneficial. And then other schools may be looking to the physician for very clear and explicit direction. And so I think what's important is that we discuss some example academic adjustments so that if the schools are asking you for them, you are familiar and aware of what to provide. So some key concepts in Return to Learn and these supports is remove, reduce, and pace. So we want to remove non-essential or just busy work. We want to reduce the workload in the classroom and any repetitive work, and really focusing on quality and not quantity. So I remember back in the day, right, we had like 50 math problems to do, and it seemed a little bit excessive. But can we suggest that the teacher just provide the student 15 math problems in order to show mastery of the assignment instead of 50? And then lastly, the concept of pacing. Allow for 5 to 10-minute breaks in the classroom after periods of mental exertion. And the recommendation around this is that if a student is experiencing a headache, right now their headache is at a 2 out of 10, and it goes up 3 points. So now they're at a 5 out of 10. It's good for them to take a quick 5 to 10-minute break, wait for that concussion to go back down to a 2, and then re-engage back in the learning environment. We can also consider shorter days during that first week. So starting school a little later or ending school a little later. And this is the concussion symptom wheel. And it takes common concussion symptoms and it breaks it up into 4 domains: physical, cognitive, emotional, and sleep. And so really quickly, I'm going to go through each domain and then just provide some example academic adjustments that help match this domain. So for this physical domain, things like headache, dizziness, right? Going back to that concept of pacing, short, frequent breaks, where we can schedule longer breaks during a dedicated time. What I typically recommended was that a student have a dedicated time mid-morning and then again in the afternoon, but it was always something that was scheduled, and it wasn't something that they could just take whenever they wanted, because what we end up seeing is that some students are going to abuse that system and just leave class whenever they want. So a little bit of behavior management in there. Provide a quiet place to spend lunch. Definitely want to remove them from PE and dance, and then always without penalty. And if they need to, sit out of music or orchestra if their symptoms are provoked in those types of classes. In the cognitive domain, removing and reducing the workload. Extra time on classwork and homework, but always providing a firm deadline. I say this every time I always talk about this firm deadline, but if you work with teenagers, if you have teenagers, you know, if you were to tell them, just get it to me when you feel better, right? They are not going to do it. They're going to procrastinate, and then it's going to be the end of their recovery period, maybe 3 or 4 weeks later, and now they have a mountain of assignments to make up, and that now, right, they're behind in school and they need to catch up. And so when I'm making a recommendation to a school, I'm always saying, please provide them extra time on classwork or homework, but only give them 3 extra days to do it. So this firm deadline really helps them to just kind of keep on track. Buddy note system, teacher notes, study guides, and then again, extra time on exams, or even considering different test taking methods. So instead of having the student write an essay, can they have an oral presentation with the teacher to demonstrate mastery of content? The emotional symptoms, right? We often see an increase in emotional symptoms after an injury. So for some students, it can be really challenging to navigate. And so we want to be able to have them have check-ins with school counselors, or if there's another adult on campus that they really trust, have them have check-ins with them. Encourage them to stay connected with their friends and teammates. We don't want them to socially isolate because that's when we really start seeing some secondary emotional symptoms as well. And then I also want to just really highlight that it's important to normalize the experience, especially for those patients, right, that maybe seem really anxious at that first appointment. Just explaining to them, right, this is normal, right? This is very typical. We see this often with concussions, and we expect that when your concussion gets better, your anxiety is going to start resolving as well. That helps to give them something to ground on, a little bit of like concrete information so that they're not thinking in the future of like, what if, right? What if I don't get better? Am I always going to be this anxious? And then sleep. So again, the concept of pacing, starting school later, ending school earlier. And then very, very, very important to reinforce good sleep hygiene just in general. We want them to get restorative sleep at night, 8 to 10 hours of restorative sleep at night, and discourage nap taking, because if they're taking long naps during the day and that's keeping them up at night, then they're not able to get that restorative sleep that we're stressing. So those are just examples of some academic adjustments that's really supportive during that tier 1 and that initial phase of the concussion. So again, that first 1 to 4 weeks. And now we're going to switch gears really quickly and talk about the overlap of mental health and concussion. So with mental health, right, we see children with concussion experience significantly higher levels of the internalizing, externalizing, and these overall mental health difficulties in comparison with the control group. So those internalizing symptoms, the things that person is experiencing inwardly, the anxiety, depression, post-traumatic stress. The externalizing symptoms are the behaviors that we see outwardly: conduct problems, aggression, inattentiveness, hyperactivity. And in this study, it demonstrated that concussions impact the emotional health specifically in athletes. About 61% reported their injury upset them, 47 were worried about the injury, 41 were fearful, and 25% were anxious. So we're seeing a lot of these emotional symptoms that's co-occurring with a concussion injury. We do know that mental health affects symptom reporting, symptom severity, and the recovery process. And interdisciplinary care, right, similar to what we talked about earlier, it really helps to improve outcomes, and it specifically helps to mitigate the poor mental health outcomes. There is a connection between concussion and poor mental health and academic outcomes. We know that baseline challenges, so any pre-existing baseline challenges, are usually exacerbated after a concussion. And this is in like that first 1 to 2 weeks. As the concussion resolves, we typically see some of those challenges start to return to baseline as well. And the depleted cognitive resources from the concussion can unmask some pre-existing difficulties, right? So if their brain is in an energy crisis and they're no longer able to access their compensatory strategies that they were once able to, it's really going to start exacerbating some pre-existing challenges. Dr. King, if you want to jump in at any time, feel free.
Thank you. You're doing a great job.
So these are just an overview of some vulnerabilities that are highlighted by concussions. We have our neurodevelopmental disorders, things like ADHD and learning disabilities, our mood disorders, anxiety, depression, neurocognitive functioning, so executive dysfunction, slowed processing speed, emotional behavioral, right, increased impulsivity, behavioral dysregulation, and social withdrawal. I'm gonna go through each of these different categories real briefly. This first one being neurodevelopmental disorders, so our ADHD and learning disabilities. So typically what we see at baseline with this group is that they're scoring lower on neurocognitive testing, just generally scoring lower on neurocognitive testing, and they do have a higher invalidity rate. And so this is going to be things like the impact test. They also at baseline have higher symptom scores. So symptoms after they sustain a concussion, the concussion usually makes their behavioral and cognitive symptoms more debilitating. So again, we're seeing this initial increase in symptoms. As the concussion gets better, those behavioral and cognitive symptoms start going back to baseline as well. The recovery period, so ADHD and learning disabilities, it strongly affects time to recovery. And this group often experience a little bit longer recovery periods. And then with our lifetime risk, specifically for the ADHD group, there's a higher risk of them sustaining concussions, and they're actually 3 times more likely to have a history of 3 or more concussions throughout their lifetime.
And I think clinically with these group, for those kids that already have had supports in place with the school, that is a complete gift. And usually you just have to figure out who's in charge of that support system for the school and then make sure that your letter that they had a concussion gets to that person because they can easily shift these adjustments for them in school. The harder population are the kids that are just surviving and just under the radar and have had some mild learning disability or ADHD. So those are the kids that sometimes will end up having a learning support plan after the fact because kids don't know what they don't know. And they just thought that maybe it just takes them 3 times longer to do all their work because that's just how they have always functioned. But then sometimes the concussion will actually bring this to the surface, and then it presents an opportunity to actually build these supports for these kids. So that's that small population that end up getting supports after a concussion, even if they did not have them prior to.
Thank you. Next, I'm going to talk about mood and suicidality. Specifically with anxiety and depression, again, baseline symptom scores are significantly higher. So, right, the kids that you see with anxiety and depression, their baseline symptoms are already higher. And then they get a concussion, and during this acute stage, they're endorsing a higher number of symptoms and also experiencing a greater severity of those symptoms. And the recovery process, it is linked to symptoms post-concussion. So it is showing it's taking them a little bit longer to get better as well. And with regard to suicide risk, in the literature for many years, it was mixed findings. Some studies saying, right, there is no increased risk for suicide, others saying there is. In a 2025 systematic reviews, this is one of the most recent studies that came out. They did find that sports-related concussion is a risk factor for suicidal behaviors, including suicidal ideation, making a plan, and attempted suicide. Additionally, athletes with a concussion in comparison to athletes with an orthopedic injury had more mental health visits, psychiatric hospitalizations, and reported self-harm. And I just want to highlight, right, that concussions do affect, right, because of our cognitive resources being depleted, right, we're not able and we're not at our best to regulate our emotions. And it's really this disruption in cognitive functioning. It creates this limited capacity for any person to be able to manage these symptoms, these emotional symptoms, these behavioral symptoms, and then put out those day-to-day fires that we experience. So with that, I just want to reiterate, it's important that interdisciplinary approach is very important, keeping an eye on these secondary mood disorders, these mood symptoms, so that we're getting that support in place if needed, that behavioral health support in place. And these, just real quick before we wrap up, these are some free resources that are available for families and schools. The QR code links to HCAMP's website. It's our homepage, and on that homepage, there's access to HCAMP BrainSpace, and then these fact sheets. So BrainSpace is a free online education course that's available for parents, teachers, or parents, educators, coaches, and referees and officials. And then these fact sheets are available to download and print. So if you want to provide them as a resource for families, as a resource to schools, please feel free to do so. And then I'll let Dr. King share this one.
So this is just a good handout that was actually made for the emergency room in PCP offices. So this just kind of goes through the initial things of how to manage a concussion in the very early phases. Oftentimes, if we can get these implemented early on, then we know that the recovery is going to be a lot faster. We did have a QR code. Apparently it was broken when HPH went to the new website. So as soon as they fix it, which they're working on now, I will send it to Summer so that she can distribute it to everyone in case you're interested in using it.
And with that, these are our references. And then again, the QR code to the HCAMP website. Oops. Are there any questions?
Thank you for a great talk. There probably are additional questions, but I don't know if there's any further follow-up on kind of the gender differences between the like the recovery that you were talking about earlier. And then one of our participants had asked if there was a delay in diagnosis, and Jen, you had said not really. Um, so it's not a delay in diagnosis that's causing the prolonged recovery. It's just the fact that they seem to take longer. Is that correct?
Yes, and there's like multiple reasons that we're still trying to tease out. I mean, a lot of these are adolescent females, so we're contending with a lot of hormone dysregulation, trying to figure out what their bodies are doing. And it seems like most of the early studies, and I don't know that anyone's tried to repeat it to see if it's true, but females tend to actually report symptoms. And so when we talk about teenage males, they tend to underreport, even though as a population, athletes just underreport in general. But it does seem like males are a little less intuitive to their bodies and tend to not report the symptoms, which may be why they actually progress faster because they don't report the symptoms as they're going through the progression.
Thank you. That's a really good point. Erica, do you want to just unmute and ask your question if you feel comfortable?
Yes, so sorry. I was like, this might be more of a niche question, but I was wondering because I think we're all familiar with the 6 step, return to play, return to school program. I guess at what point do you allow them to progress from one step to another? Is it, because previously it used to be you have to be symptom free at step one before you go to step two or et cetera, et cetera. But I don't really know what's a good cutoff. Is it like if it's a headache, if they have it, if it's less than 2 out of 10 for most of the day? I guess that nuance is always a little bit gray for me.
So this one's a little tricky just because of the way that the Hawaii law is written right now. Technically, they're supposed to be back to school before they start return to athletics, but that does not mean they can't return to exercise. So the most recent concussion consensus statement split up the return to play into the therapeutic aerobic individual exercise versus the actual progression, which is now team-based and actually working with the team and progressing. And so for us, we use the rule of twos. Like if you have a headache, I'm not going to wait till that headache goes away before we start some early exercise because there's that subpopulation that will continue to have headache until they start exercising. And so we want to get them back to aerobic exercise. We use the rule of twos. This has been vetted by a lot of good studies by Dr. Reddy or Dr. Letty. And so if we can basically keep their symptoms from changing less than 2 on a 10-point scale, we let them do that amount of activity, whether it's academic cognitive work or physical activity. And then we used to also wait for weight training because there was a theory that, weight training kind of increased how much blood flow was going to the brain and was that changing the recovery rate. But obviously there's kids that we tell not to weight train and they do it anyway, and the recovery is no different. So if they're the kid that hates cardio, but they love weight training, then we have them get back to their weight training. They just decrease how much weight they're doing from their baseline and then slowly increases tolerated, keeping those symptoms within a rule of two. Oftentimes, it depends on the athletic trainer. Some athletic trainers feel comfortable, depending on how you read the Hawaii law, that they'll do the aerobic activity with them in school. But others will say, we can't do it until you're symptom free in school. So then we want them to do some of that activity at home if they can't do it in school. Does that
That's
help,
really
Erica?
confusing still.
Yes, I think yes, for sure. I think maybe I'm not familiar with the rule of two. Is it like you say you start your activity at like I have a headache before going on the computer and I start at a 4 and
Mhm.
if it increases to more than 2 points, so like if I get a headache and I'm out a 7, that's when I stop. Is that the rule of two? I'm just
Correct.
guessing. Okay.
Correct. Yeah. And a lot of that came from the fact that one person's 2 is another person's 8. So it's really hard to just pick a number. Because
Mhm.
sometimes I'll walk in and have a super smiley kid and I'm like, what's your headache right now? They're like a 10. And I'm like, not a 10. right? So I think using the rule of twos can take that subjective portion out a little bit so that now we can at least get them back to some kind of level of activity.
Got it. Thank you so much.
Jamie, anything else?
No, not at all.
Okay.
Thank you.
Jamie, I was curious, what is the level of like understanding of these recommendations at the individual school or teacher or coach level? Are students and families getting a lot of mixed messages, or has there been really good like education throughout the school system about this, public
That's a,
and private for that matter?
that's a great question. Yeah, it is widely varied. So from one teacher to another, from one school to another, it can be managed completely differently. Um, Oftentimes, it's how confident does this teacher feel in applying some of these strategies in the classroom. Um, Other times, a teacher does not feel very confident, and they're really looking to physicians to be able to direct and prescribe various supports. Um, an initiative that we're currently working on HCAMP specifically is creating this return to learn protocol and policy for the DOE, the Hawaii DOE specifically. And so we want to be able to educate teachers and school systems so that there is a return to learn plan in place for both athletes and non-athletes. And with that, we're hoping to just raise their capacity and confidence in being able to manage these cases within the school system. And so to take kind of that direction away from the physicians to be able to say, right, like we want the physician to be able to direct everything. We want to give the school some autonomy to do that. Dr. King, would you add anything with that?
No, it is dependent on the school. And then, your biggest gift is a teacher that's had a concussion before, because they're the ones that will definitely modify. And experienced teachers tend to be more comfortable doing it than newer teachers. So I think sometimes when there's a lot of turnaround in the school, that's where it gets a little bit tricky. And I've heard it from before where I always joke that the worst time to get a concussion is your freshman year of high school, because you're just trying to figure out high school anyway. And so the teachers are like, well, they don't advocate for themselves. And I'm like, well, they're freshmen. So like, I don't expect them to advocate for themselves. So here's my letter. Can you please help them out? And so trying to get the teachers to look, because if they actually look at the grades, that's where they can see the changes, right? So the kids that were getting like 80s and 90s for the first few weeks of school and then get a concussion, and now they're getting 70s consistently, obviously they're struggling and having a little bit of trouble. So just trying to get to a little bit of buy-in is usually helpful.
Erica, do you want to just unmute again? I think your questions are excellent, so don't be sorry.
So sorry. Yeah, I guess my question is, I'm on the island of Kauai, and in Kauai to get into PT in a reasonable amount of time is quite unheard of. And so I understand that, if children are having symptoms beyond the week, we try to get them into physical therapy as soon as possible. But is there a certain series of exercises that not you automatically prescribe, but is there something that would be helpful in the interim until they can get into PT? For us, it averages about 2 or 3 months to get in.
So Erica, if you go to any of the concussion patients we've sent to you that have a home exercise program, it's the same one. And
Okay,
then so feel free to share that QR code. It's pre-made. So
got
usually
it.
if you don't know which ones they need to do, any of the ones that aren't easy or make them symptomatic are the ones they should be doing, because those are the systems they probably need to reset. We do modify it a little bit for the littles. So little kids will not want to sit and do this and look between their two thumbs, right? And then, so are there any games that they can play that do the same kind of activity? Sometimes we'll have them do like a Lego set build in the middle. The directions are on one side, the pieces are on the other, and then they have to look and track back and forth to be able to do that. If they like ball sports and a responsible adult will play with them, you can have them try to pass the ball back and forth while they have to track with their eyes. So you can adjust it for the littles, but once they hit teens and they're in organized sports, if their buy-in is to do these exercises to get back to sports, they're going to do them.
Perfect. Thank you.
Mhm.
That was insight into what happens in the brain when the kids are doing the exercises for anyone that saw Dr. King's background.
It's exactly what they're feeling, right?
Yeah, exactly. 100%.
Yeah, I didn't know Zoom had that. I'm used to it from FaceTime, but that was cool.
That was great.
We have a little bit more time, folks, and if you have any other questions, please feel free to unmute or drop questions into the chat. I don't know if we have questions to like quiz questions for post presentation. No, okay.
Just because that was for CME, so
Got it. Okay. Well, I have one more question that I was thinking about when Jamie, you mentioned like getting rid of busy work in school
Mhm.
and also like having an extension on time to complete assignments, but at the same time, like being strict on that.
Mhm.
Um, I mean, my general idea, sort of my general position as a parent is that they shouldn't have busy work in the first place because it's just annoying. But obviously,
100%.
that's not how it works in real life. So,
Uh-huh.
how do you kind of like go to a teacher and be like, this is stupid, and I think the student should do that? Like, how do you actually like decide what is like where they should spend their time and like what proportion of the assignments they ought to be doing like at each
Right.
phase?
That is something that is completely dependent on the teacher, right? So if we're thinking like middle high school level and they have 6 teachers, I encourage the patient or the student, right? Ask your teachers to reduce some of your schoolwork. Not all 6 teachers are going to do that, but if 3 of them do it, then that's great. Like we'll take what we can get, and we'll just manage the rest. And so that's one way that I kind of facilitate that conversation with the student and the teacher, and then usually just like an email to the teacher or something of I definitely don't say get rid of your busy work. I think that would cause just some contention maybe, but just encouraging them to reduce the workload. If there are assignments that can be taken away, please take it away, and don't penalize them for it.
So it's basically like triaging, like this is important for learning as opposed to just drilling or something drilling. Haha. I don't know if you guys can hear the drilling in the background. But so kind of prioritizing, as Renata said, prioritizing the assignments and then trying to be reasonable about what this patient can actually complete as a student so that they're like somewhat challenged but not overburdened.
Yes, exactly. And this is all based off of, right? So it's hard to say very explicitly because it's very individualized for each concussion patient. And so it's based on their symptoms. If right, this workload is way too much, then having that conversation with the school or encouraging that patient to have the conversation with their teachers about what else can be removed. What other assignments can be removed, if any.
Got it. Thank you.
Mhm.
All right. Well, this was an excellent talk. I learned so much. And, we don't see a ton of concussion patients in the hospital, but we certainly do see them. And so having a good understanding of how to kind of help them know what to expect as they get discharged and go to outpatient management will be really helpful. So thank you both for really excellent information. I don't see any other questions in the chat. If anyone does have one, it's a sort of like speak now or forever hold your peace moment, folks. Um, Feel free to unmute real quick and ask, or if not, then we will go ahead and say thank you so much and look forward to seeing everyone in a couple weeks.